Okay, guys, welcome back. This time we shall be talking about a topic by the name of mitral valve prolapse (MVP). Earlier, the name for this condition was floppy valve syndrome, or a third name for this was Barlow syndrome. We will today study what are the causes for development of this and what will it ultimately lead to. And if you look at the adjoining image which is present here, you will notice that there is a definite billowing of the mitral valve leaflets. I'll just zoom it in. You can see that the mitral valve leaflets are rather pushed up higher than normal than what they normally should be during the phase of systole. Now, when that will happen, there would be extra stress that would be present on chordae tendineae, and these chordae tendineae are powered by muscles. The muscles which are present here are called as papillary muscles, which I'm highlighting now. So what is happening in this patient is that the valves are going up much higher than normal. The stress on the papillary muscles and the stress on the chordae tendineae will also affect the subjacent myocardium. You see, in this area, because there is repeated stress much more than normal, there is a hypoxia developing in this part of the heart, because of which in these patients in the long run there can even be a propensity for arrhythmias. This is the first time that I'm telling you that a valvular lesion can contribute to development of a ventricular arrhythmias in a patient. Now, normally I have spoken about mitral stenosis, where I've said structural damage to left atria will cause atrial fibrillation, but in this case I'll repeat my statement again. The valves go higher than normal, the stretching of the chordae tendineae put undue stress on papillary muscles, and the undue stress on the papillary muscles results in a subendocardial ischemia that can be responsible for development of arrhythmias in this condition as well. So let us now study regarding why would you be having is a development of MVP in an individual. So we will first talk about causes of development of mitral valve prolapse, and the leading cause why this occurs is because of the myxomatous degeneration of the mitral valve tissue. What that basically means is that there is a defect in the collagen arrangement and the type of collagen which is present here. According to pathology questions, or for the solving the pathology questions, I want you to remember that mitral valve prolapse has a defect of type 3 collagen, and there is broken myofibrils in the valve tissue, and because of the myxomatous degeneration of the valve tissue, the end result is it bulges up much higher than what it normally should, and therefore we can also be having a development of murmur in the patient, because the valve leaflets would go up, then get separated, and there is a leakage of blood from LV to LA. So mitral valve prolapse can also result in a development of primary mitral regurgitation. I'll repeat both the facts again so that you can make a better orientation. One, I told you the leading cause why do you get mitral valve prolapse is myxomatous degeneration, and what is the complication that it will cause is a development of primary mitral regurgitation in a patient, and this myxomatous degeneration is because of the defective myofibrils, in a sense that type 3 collagen is defective, so the valve billows up higher than normal. The second cause why could you be having mitral valve prolapse is with respect to connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome. For Marfan syndrome, I would just like to show an image to you where you can definitely notice in the patient rather very long digits. So the term that we have studied so many times for Marfan syndrome is arachnodactyly. Marfan is a defect of chromosome number 15. The protein which is defective is fibrilin 1. And you can see that when you will ask the patient to flex his thumb, the thumb can basically protrude even behind the wrist of the patient. So hyperextensible joints in the patient is present. And what I've shown here before you is simply a thumb sign of the patient, which is very characteristic for patients of Marfan syndrome. Patients of Marfan syndrome can die because of aortic dissection. They can die because of rupture of aorta, but then they could be having MVP as well, or mitral regurgitation developing in the long run. Another connective tissue disorder which is referred as rubber man syndrome. You can see the extensively stretchable skin of the patient. So they can give that as an image-based question also. That is a rubber man. Ehlers-Danlos syndrome is a connective tissue disorder which is associated with development of mitral valve prolapse in a patient. The third one for MCQ sake to be remembered is osteogenesis imperfecta. Yeah, the same condition in which you read about a blue sclera and multiple fractures present in the most severe variety. The same condition can also be associated with MVP. Then are the standard conditions like rheumatic fever, But before I take a mention about rheumatic fever, which is obviously easy and you know about it, I would like to mention regarding a condition which is relatively rare, but I'm writing it first because MCQ wise is important, by the name of straight back syndrome. Now, what this condition means is that there is a loss of thoracic kyphosis. And therefore, due to the loss of thoracic kyphosis, the antero-posterior diameter of the chest becomes relatively lesser. So the heart is relatively sandwiched between the sternum and the thoracic spine. The main feature of straight back syndrome is antero-posterior diameter of the chest is relatively lesser, so the space available for the heart is also lesser. So the heart gets in a way sandwiched between, I said, the bony parts, that is the sternum, rib cage, and the thoracic spine, and therefore the presence of I would say this sandwiched heart between the limited chest cavity results in development of mitral valve prolapse in a patient. In fact, this is a rare fact, but then MCQ wise is relatively more important than the standard causes like rheumatic fever. Rheumatic fever will be having Ashkoff nodules, so they can be causing degeneration, damage to chordae tendineae and the papillary muscles, and then you could be having mitral valve prolapse and MR, or it could be subacute bacterial endocarditis, where there would be infection, there would be vegetations that can cause damage to the chordae tendineae and papillary muscles in a patient. And other causes for this could be like dilated cardiomyopathy, where there's a structural damage anyway. So dilated cardiomyopathy has a etiology like alcohol, or it could be due to sarcoidosis, it could be due to toxins, it could be due to steroid use in viral myocarditis. So dilated cardiomyopathy anyway will cause a dilated mitral annulus, and mitral valve prolapse can be associated in the congenital heart disease associated is by the name of ASD. So these are the usual causes. Why would you be having a development of MVP in a patient? And from the pathophysiology perspective in this particular disease, the biggest problem in this patient is, as you can see the billowing of the valve, you can see the valve leaflets are rather pushed up relatively further up. So the basic problem in these patients is excessive stretching of the papillary muscles. There is excessive stretching of chordae tendineae. Chordae tendineae are these anatomical structures in the undersurface of the valves which helps the valve leaflets to close properly. So two things are happening here. One is the excessive stretching of chordae tendineae, which are connected to papillary muscles. This is going to contribute to two things. One, there will be auscultatory finding created here. The reason for this auscultatory finding by the name of mid-systolic click is the tension which is created. When I'm saying excessive stretching, it means like a rubber band, the chordae tendineae is getting stretched. So due to the extra tension which is created in the chordae tendineae in the valve leaflets, due to stretching of them much more than normal, as the valve goes higher, it's not able to hold its position. Please appreciate the fact that in you and me, the valves are able to hold their position. On the undersurface of the valves, the chordae tendineae ensure the fact that not a single drop of blood is ever able to leak from the ventricle side to the atrial side. You see, in you and me, the ventricular pressure is obviously more than atrial pressure. Not a single drop of blood is able to leak because the structure is so rock solid that the valve is able to hold its position. But in this case, you will see that the valve billows up, it's not able to hold its position, and the leakage of blood can even result in a development of murmur in the patient. But before the development of murmur, the event that will be heard in this case is called as a mid-systolic click. Do not confuse with ejection click. Ejection click simply means opening of aortic and pulmonic valve. Here, there is a mid-systolic click. Why mid-systolic? Because maximum pressure will develop in the middle of systole. So with the billowing of the valve, the stretching of the chordae tendineae results in a mid-systolic click developing in an individual. The second problem that will develop in this individual because of this would be development of ischemic damage in the myocardium, or rather ischemic damage in the subendocardial area, which can be a reason for development of arrhythmias which can develop in this condition, like ventricular tachycardia or even premature ventricular contractions, or PSVT can even be present in the patient. So I repeat the fact here. Two problems of this patient is, one, the tensing of the valve leaflets and the incompetency of the valve leaflets resulting in leakage of blood. And the second problem of the patient is the ischemia of the myocardium, which will explain the symptoms of chest pain that could be present in the patient. Let us now look at the clinical features that would be encountered in mitral valve prolapse. If the MCQ simply says what is the most common symptom or the most common presentation, then it is asymptomatic because it takes some time to develop. Most of the time the gender will be female, age group will be between 15 to 30 years of age, and the next symptom that you will notice in the patient will be development of a substernal chest pain. Lot of these patients will think that they're having some kind of GERD, and lots of these people would actually be seeing a gastro unit who would be prescribing maybe PPIs to these patients on empirical grounds. But the substernal chest pain will usually continue in these patients because of the ischemia component, and then these patients might even complain that off and on, even while sitting on a chair, I tend to have my heart racing in my chest, due to which they might be misdiagnosed as having panic attacks or anxiety. In fact, I've personally seen cases where the person was on this young doctor. In fact, she had done medicine, and she was having this problem herself for so long, and she thought that it's a panic attack. She was on anti-anxiety medication, and when a routine ECG monitoring and a Holter was done, then it was found that the reason for why she was having these palpitations were multiple PVCs that were coming. So she anyway had to take treatment for it. Why I'm saying that is because if a doctor is having a disease, a IMD medicine person is having the disease, and this person is not aware that this could be due to a cardiac lesion, because you see, with our body we tend to think, well, nothing is going to happen to us because of the stress of our medical college life or the excessive duties that we do. We tend to neglect our body so much that we tend to think that we are imagining that there's something wrong, right? So most of us, it is taught to us like this. When a doctor studies a disease for first time, he thinks that he's having the disease, but lots of time your body is telling you, that you are working much more harder than normal. And that's the right thing to do, but there are some symptoms like cardiac symptoms if coming up. A proper thorough checkup should be definitely be done, because after all, a healthy body can be resulting in a healthy mind. Coming back to the agenda, guys, I just want to say that premature ventricular contractions, ventricular tachycardia, PSVT, and even atrial fibrillation. Why atrial fibrillation? Though the problem was in the ventricles, is because ultimately the blood will go from LV to LA, so there's a structural dilatation of the left atria, and that can trigger even a structural damage to left atria, can trigger a atrial fibrillation in these patients as well. The next reason why these patients can come to you is if there's a development of infective endocarditis. Why infective endocarditis? Because mitral valve in our body operates at the highest pressure gradient, so the incidence of infection can definitely be higher. Because this condition will result in mitral regurgitation in the long run. Mitral regurgitation has high predisposition to development of infective endocarditis. In fact, there's a possibility that the vegetations might even go to the brain. So transient ischemic attack has also been reported in literature for these patients. That is because of the platelet plug or the fibrin deposits that will occur on the heart valves of the patient, and they can embolize to the heart of the patient. And then in case these patients go into development of frank mitral regurgitation, then they can develop acute left ventricular failure, and they can even have a development of SCD, that is a sudden cardiac death. So these are 6 reasons why these patients would come to you, with the leading cause being remembered as the asymptomatic. Let us now look at the auscultatory finding that would be found in these patients. To help you remember this on a long-term basis, I'll just draw a quick diagram so that you can remember it better. On the right-hand side, you can see the tricuspid valve bulging up during the phase of systole, and you can also notice the mitral valve, which is going up much higher as compared to normal. So higher the valve will go, the structures which are present on the undersurface, the structures on the undersurface are chordae tendineae, they would basically be stretched much more than normal. So the tension that develops in these chordae tendineae will result in an auscultatory finding that's called as the mid-systolic click. Appreciate the fact that in these patients, first you will be having an ejection click, because first the aortic and pulmonic valves will open, so it will cause 80 ml blood to rush into aorta, 80 ml blood into pulmonary artery, and then there will also be extra tension. So I'm just putting marking here to say there is extra tension in the middle of the systole. Why I'm saying middle of systole is because max pressure is generated in the middle of the systole. So when you auscultate this patient, like this is S1, S2, period between S1, S2 is systole. So after S1, I first shown symbolically ejection click, and then there would be a couple of mid-systolic clicks in this individual. These mid-systolic clicks are due to development of sudden tension, which is developing in the slack chordae tendineae, Why I'm calling them slack is because, as I said initially, there is a myxomatous degeneration happening. In fact, in the long run, these chordae tendineae might be damaged to such an extent that a frank mitral regurgitation will be developing in a patient. So now what I'm showing in the patient is that the blood will lift the valve leaflets and will also be able to leak from LV to LA, which will explain the left ventricular failure that will develop in these patients. The sound of this blood leaking will be heard after the mid-systolic clicks, because first the valve will go up and then the blood will be able to leak. The murmur that is heard in this particular condition would be called as a late systolic murmur. As you can see here, the intensity of this murmur will first rise and then obviously fall down. So this murmur will be called as a late systolic crescendo decrescendo murmur. What I want you to pay attention to the fact is that earlier I have talked about crescendo decrescendo murmur with respect to ejection systolic murmur of aortic and pulmonic stenosis. But in this case, you can see that the term that I've used before you is called as late systolic crescendo decrescendo murmur. I'll give you one more representation so that you can appreciate this better. You see, if I am talking about a disease by the name of aortic or pulmonic stenosis, let's look at this diagram here. If a person is having a valvular aortic stenosis like this, then in those circumstances, when the left ventricle will contract, there will obviously be turbulence when the blood will go out of this narrowed valve. So in a patient who's having a valvular aortic or a pulmonic stenosis, the murmur will take off like this, and then the intensity would go down. This murmur is starting right from S1 and then the intensity is going down. So this would also be called as a crescendo decrescendo murmur, but the term I'll use to describe this is a ejection systolic murmur, and the peak intensity of this murmur is coming back in the middle of systole. So this is a ESM, ejection systolic murmur, or a crescendo decrescendo murmur, which has been described for a valvular lesion by the name of aortic stenosis or contralateral side pulmonic stenosis. But if I minimize it and show you the two diagrams, I hope by the representation here you can very well clearly see that in the superior diagram, the topic of interest, mitral valve prolapse, I have shown regarding a late systolic crescendo decrescendo murmur. Another technical input I would like to give you is that he can definitely, just to make it more difficult for you, talk about the involvement of the posterior leaflet or the anterior leaflet. Most of the time, it is the posterior leaflet of the mitral valve that is usually involved in mitral valve prolapse. What happens when posterior leaflet is involved is that the regurgitation jet is usually directed anteriorly. That is more of physics. I would say that if the posterior leaflet is damaged, then the jet of leakage of blood is directed anteriorly, and if the anterior leaflet is damaged, then the jet of blood is directed posteriorly. Now, therefore, because of this concept of physics, which I said, the posterior leaflet damage causes regurgitation of the blood anteriorly. The radiation of the murmur therefore occurs to the base of the heart. So do remember this statement: posterior leaflet involvement causes radiation of the murmur anteriorly. Just remember opposite, posterior leaflet, anterior jet of blood, anterior leaflet damage, posterior jet of blood. So the radiation of the murmur is towards the base of the heart. However, if the anterior leaflet is affected in the patient, then the jet of blood will be directed posteriorly, and therefore the radiation of the murmur is usually towards the axilla. So there's a possibility in the MCQ that either he might say murmur radiating to the base of the heart, or he might say murmur radiating to the axilla or to the back, and a common murmur that radiates to the axilla is that of mitral regurgitation. So therefore you can definitely get confused on reading the statement, but in mitral regurgitation there would be a pansystolic murmur. But in mitral regurgitation there will be a pansystolic murmur. So if you read about pansystolic murmur radiating to the axilla, it is mitral regurgitation. If you read about a late systolic crescendo decrescendo murmur radiating to the axilla, that tells you the fact that there is a damage to the anterior leaflet in the patient. We shall now be studying regarding how the murmur of mitral valve prolapse is affected by standing and squatting. You see the fact that whenever a person will stand, then the venous return to the right side of the heart will definitely reduce. That means the amount of blood in the cavity of the heart will be relatively lesser. But if a person will squat, then this will contribute to increase in the venous return to the heart, and more venous return would mean that there is more blood in the cavity. Now, the basic logic why the murmur duration changes is because of the fact that the prolapse that occurs in the upward direction is inversely related to the size of the cavity of the left ventricle. Though this is more of physics, but I'll still try to explain this to you. What I'm saying is that when the cavity will become, suppose, enlarged, the pressure will be dissipated horizontally, so the prolapse will be lesser. I repeat my statement. If there is more blood in the left ventricular cavity, when the pressure will dissipate horizontally, when the ventricles get dilated because they're compliant, so when the ventricles distend horizontally, the prolapse will become relatively lesser. Vice versa for if the cavity is relatively smaller. So let's just practice it here. Suppose I have asked a person of mitral valve prolapse to stand. This is gonna decrease the venous return. This means the fact that the amount of blood in the cavity will be relatively lesser. Therefore, the prolapse that will occur will be relatively more. And if the prolapse will be more, then the mid-systolic click, MSC is the mid-systolic click, will occur relatively earlier. Let's practice this once again. When I will ask this person to squat, there will be an upgrade of venous return. More venous return would mean that there will be more blood present in the ventricular cavity. And remember, the prolapse is inversely related to the ventricular cavity size. So this time what is going to happen is that the prolapse of the valve will occur or will become lesser. Therefore, the mid-systolic click, because prolapse is lesser, the mid-systolic click will occur relatively later. Therefore, you can see that standing and squatting both are changing the position of the mid-systolic click. This is what I'm saying. Please pay utmost attention to what I am doing on the board before you. This is the representation of S1 and S2. After S1, I've shown is the ejection click, and then I have shown that on squatting in an individual, because the mid-systolic click in the patient will occur relatively later, so I am shifting the position of the mid-systolic click in the patient. You can see as compared to earlier, the mid-systolic click is occurring later, and after that, obviously, there can also be a murmur of leakage of blood. That would be a late systolic crescendo, decrescendo murmur. So, final output is like this, that the duration of the murmur is definitely changing. This change in the duration of murmur is what I've tried to explain. Even in my topic of murmurs, when I've discussed with you, I have said, and I'll speak slow this time, all murmurs decrease with Valsalva standing amyl nitrate. Decrease with Valsalva standing amyl nitrate, except HOCM and MVP. Hypertrophic obstructive cardiomyopathy and mitral valve prolapse are two exceptions to the rule. The mitral valve prolapse relatively becomes longer. You can see here that on standing, the mitral valve prolapse murmur is relatively longer, and on squatting it is relatively shorter. So MVP and HOCM will always behave opposite of what the traditional murmurs will behave, and here is the reason why I have why this is all happening. So we call this dynamic auscultation, and one of the primary reasons why I have discussed mitral valve prolapse, though it's a very small topic, is mainly to highlight on these aspects which are to be remembered. We will now talk about the workup of these particular patients. The first test that is to be done in the patient is ECG, because it might pick up some incidental premature ventricular contractions, because a lot of these patients, when they come to you, they have complaints of palpitations. Most common presentation is asymptomatic, but yeah, symptomatic patients could be having both a chest pain as well as palpitations. So we need to take care of the patient from the ECG perspective, and then we'll do a echocardiography. Now, why we do a echocardiography in the patient is because of the fact that I would be able to demonstrate the bulge of the valve. So the bulge of the valve more than 2 mm above the plane as compared to the tricuspid valve. You see both valves are going up, so the bulge more than 2 mm is usually one that is encountered, and along with this in the Doppler you will be able to see the presence of leakage of blood. That would be a late systolic murmur that would be developing in a patient. The turbulence would come in the later part of the systole in the patient. For management of these patients, one prophylaxis for infective endocarditis may be warranted. Beta blockers are required for this patient so that we can control the palpitations part in the patient and the damage to the subjacent endocardium of the patient, because there's a repeated stretching of the valve leaflet, there's a repeated stretching of chordae tendineae, and there is a I would say repeated stretching would contribute to a hypoxic damage to the subjacent myocardium. Then in these patients, most of the time conservative management will work, and if there is atrial fibrillation developing in this patient in the long run, then anticoagulation may even be required in these patients. If they develop mitral regurgitation in the long run, a frank mitral regurgitation, then a mitral valve repair will also be warranted. But usually we may try to manage patients of mitral valve prolapse conservatively, and only if they tend to deteriorate on a follow-up, that is when surgery in the form of mitral valve repair or valvuloplasty would be required for these patients. So these are details which are to be remembered for this small topic. Thank you so much for listening.